Hello, everyone. I'm Dr. Megan Melody from Tampa General Hospital Cancer Institute, and I'm here with Soho Insider and Dr. Prika out of Toronto, Canada. And today we're going to be discussing a bit about her recent New England Journal of Medicine paper on glofitamab GEMOX for the treatment of Burkitt's lymphoma. How are you, Dr. Prika?
I'm good, thank you. Thank you for having me today.
Absolutely. Thank you for being here. So, for the people at home who don't know you, before we get into kind of your amazing paper that was recently published, why don't you tell us a little bit more about yourself, like your past life through medicine and where you are today and any areas of interest you have?
Sure. I'm out of Toronto, Canada, as you said. I work for Princess Margaret Cancer Centre, which is one of the academic centers in Toronto. I suppose I had a fairly linear course of, medical school, internal medicine. I thought maybe I would go into intensive care or something like that, but then fell into hematology. We're a little bit more separate in Canada, so the subspecialties are either hematology or medical oncology. So most of us that do malignant hematology have gone through hematology training. So I did general hematology training, which includes malignant hematology, but as well more classical hematology topics. We do some hematopathology, but I think I just really enjoyed the sort of treating patients with blood cancers and also just the relationships you create with patients, or I guess you have with patients over time. So I sort of fell into a malignant hematology fellowship and a master's in clinical epidemiology, and I've ended up at Princess Margaret, mostly treating lymphoma. So I treat all kinds of lymphomas in our group. We also do more specialty treatments like autologous stem cell transplant and CAR T cell therapy now for our patients. So it's just a very meaningful, I guess, course because we treat patients from beginning to hopefully cure and survival, but sometimes to other endpoints as well.
Yeah, and across a vast acuity of care, which is really, really interesting and complex way to practice medicine for sure.
Yeah, absolutely. I
So,
always tell trainees when they come through, you want to practice that's kind of a mixture of acute and indolent things, because if you just do one or the other all the time, it's sometimes can get a little bit monotonous that way, I suppose, or you burn out if you're just looking after sick patients all the time.
you're here because you just published a really impactful paper in the New England Journal of Medicine regarding the use of glofitamab with GEMOX for the treatment of Burkitt's lymphoma. I was wondering if you wouldn't mind, before we delve into the specifics, just giving us a high-level overview of your paper and what it showed.
Sure. In the it was really a case series of some patients that were had refractory Burkitt lymphoma, and were treated with combination actually of glofitamab and polatuzumab vedotin, which are both sort of targeted treatments, more used in other aggressive B-cell lymphomas and not necessarily funded or available for this indication. And sort of this collection of patients where, and especially in Canada, sometimes we have less access to some treatments off label, but we are able to access this combination of treatment in some patients that otherwise generally we think of have a fairly terminal course. And we're surprised to see that patients had complete responses when they had been refractory to really a number of lines of chemotherapy, allowing them to proceed to other consolidative treatments like allogeneic stem cell transplant and remain in remission in one patient's case over a year, and the other is closer to that. It was just very. We felt with encouragement from others that we should report this as it offers an option for treatment for patients that otherwise are generally have quite poor outcomes. And even though this is a small series of patients, it's very impactful, as you say, or encouraging to see that this could be an option when not many other things can work.
Yes, absolutely. And I apologize for our listeners at home. I was getting ahead of myself and reading one of the questions I had written. So it's Glofit Pola, not Glofit Gemox, but I am obviously going to ask you about Glofit Gemox momentarily. But before we get into that, I guess I wanted to know for the patients that were treated this way, at least in the United States, we're obviously doing glofitamab as a ramp up for in requiring some days of inpatient hospitalization. So for this regimen with the glofit polo combination, was this primarily given in an outpatient setting or inpatient setting or a combination of both?
Right. Yeah. Yes, that's a very good question. Certainly, the administration was as per the more routine experience with glofitamab in terms of having a step up. So the approach I think we would recommend is to give the obinutuzumab pre-treatment with Pola on day one, and then day 8 and 15 of the glofit step up. Certainly at our center, and I think the recommendation would still be to at least have a 24-hour admission for the first 1 to 2 doses, and then if things go well with the step up, then move to an outpatient setting. But I know centers are trialing different ways of doing outpatient bispecifics, and certainly if that's available, that would be an option. But at least the way we gave it for this was inpatient administration for the step up. But the patients did well and were able to move to the outpatient setting for cycle two, along with the POLA.
And in terms of toxicities that you were seeing with glofitamab, did you have any high-grade CRS or ICANS with the glofitamab in these patients?
Not in these patients were did well, so no significant CRS or ICANS. But I suppose for any when trying this regimen, I think it's still a small number of patients, and there's a much larger experience from other B-cell lymphomas. So still the caution with that would be recommended, I think.
What about with rates of tumor lysis syndrome or TLS? Were you seeing, just given the nature of Burkitt's lymphoma and the nature of the disease, did you see a higher rate of TLS with this regimen than you would expect in other lymphomas?
Right. So we didn't, but I think you it's probably prudent to be on the lookout for that and certainly treat with allopurinol and things like respiricase if one was worried in terms of tumor burden. A couple of the patients thankfully didn't have had reasonable amount of disease going on, but not like starting out with newly diagnosed Burkitt with lots of disease. So that was a kind of good prognostic, I guess, from the TLS perspective. But I think that would definitely be something to watch out for. Although I suppose it's interesting. Burkitt is very aggressive, but we have other, like double hit lymphoma or other high-grade B-cell lymphomas where these regimens have been tested a little bit more, probably have similar behavior. So I think just usual approach to TLS would be reasonable.
And I guess along those lines of where we've seen glofitamab studied, I think kind of what I had been alluding to at the very beginning was the recent data with the STARGLO clinical trial. For those of our listeners who are less familiar with this newer data, it's the use of glofitamab plus GemOx in for relapse refractory diffuse large B-cell lymphoma, and the results were quite promising. And so I guess as I was reading this paper, I thought the combination of glofitamab pola is quite unique. We're not seeing that as much in the diffuse large B-cell lymphoma space because a lot of our patients are now seeing polatuzumab frontline, but makes perfect sense in Burkitt's lymphoma where these patients have already seen a lot of chemotherapy. But I guess I was just wondering what had prompted you and your team to reach for this glofit pola combination over a more studied regimen of glofit gemox.
Right. So, I mean, some of it was kind of how the drug availability came to be, but I think I would perhaps think that in the Burkitt lymphoma setting, combining glofitamab with what I would say is a kind of medium intensity chemotherapy regimen like GemOx, we might not get as much mileage out of it. We know that Burkitt lymphoma, often patients get the fairly high intensity regimens up front, and then you would think that it's fairly chemo-resistant to further lines of therapy. And we certainly saw it even in these patients. Like one of the patients who was my patient had ICE and GDP and our EPOC and IVAC, like a number of therapies, and it didn't do very much. So I think we would say it's Burkitt lymphoma is probably pretty chemo resistant once you get beyond the front line. So I think combining with GemOx might not be as useful. Glofit has been tested in more high grade in sort of phase 1, 2 in grade B cell lymphoma subtypes, not including Burkitt, and perhaps that would be another question that will come, and thinking why Burkitt patients perhaps have been disadvantaged in terms of drug development because they're often excluded from trials, even though the behavior is not necessarily that different than a high grade B cell lymphoma from a kind of the concerns people might have when they develop drugs. But in the high-grade B-cell lymphoma studies, there was pretty encouraging responses of this combination, and so that was the impetus for trying to put those together rather than combining it with chemotherapy.
And then I think just going over some of your patient characteristics, I think one of your patients had been previously treated with CAR T cell therapy and had had a subsequent relapse, and two went on to receive allogeneic stem cell transplant. I was just wondering in these patients with Burkitt's lymphoma, if you are reaching for glofit pull more frequently, how you best feel cellular therapy factors into this new treatment paradigm and this treatment algorithm and sort of the most optimal way. What your opinion is based on these three case studies of the best way to optimize sequencing therapy for these patients.
Right. Yes, I think, I mean, two of the patients one had a CAR T consolidation and one had had it prior. And in both cases, it was fairly discouraging responses, I would say. And there was a recent series of Burkitt lymphoma patients published of using CAR T cell therapy, where I would say the results were fairly disappointing. Some patients do respond, but the responses don't seem to be long lasting. So certainly, at least with the products we have now, perhaps CAR T cell therapy doesn't seem as promising as in the other aggressive B cell lymphomas. So, thinking at least of these patients we had, I think if you can get a good, close to a CR with some of these treatments like glofitamab and pola, still allogeneic stem cell transplant, I feel is or seems like it's the more tried and true treatment that could offer a cure for the long term. CAR T so far, perhaps less so. So I think I'd be less and less inclined to try it if there was a chance to get to allo with a treatment regimen. I think.
I know we're just kind of wrapping up here, but before we go, I kind of wanted to know what do you think are the biggest challenges facing us currently right now in the treatment of B-cell lymphoma, and what are you most excited about in the space moving forward and over the next few years?
Yes, I mean, I think it was somewhat exciting and surprising to see in Burkitt lymphoma and perhaps extrapolating to high-grade B-cell lymphoma, this combination being so active. Um, I know that there are plans in some of the through some Burkitt lymphoma consortia or groups to add glofitamab to frontline treatment regimens and to test that. Really, what we need is more studies and more research studies in this rare lymphoma. And I think we could perhaps advocate, at least in the relapse refractory setting, that these patients should be included in studies or in trials that are testing some of these combinations, to give more access to patients to treatments, but also in many countries you need some rigorous data or at least good data to even allow funding and access to these drugs for patients. And if they're not included in trials or it's difficult uh, to study them, then often they're kind of orphaned, I guess, in having access to some of these therapies. I mean, even in Canada, we don't have CAR T cell therapy approved for Burkitt lymphoma, and even the one we did was sort of it happened in a way that they were able to access it, but it's just if they're not studied, then often we can't advocate for funding for these therapies. So I think I'd be excited to see some of these rarer but aggressive lymphomas be included because obviously there can be responses and we can hopefully cure more patients.
No, I absolutely agree. I truly feel that this paper is very impactful in our management of relapse refractory Burkitt's lymphoma. As you mentioned, these patients often see many, many lines of chemotherapy, and they have been excluded from a lot of the discussion in the T-cell engaging cell therapy space. And I think that your case series demonstrates the efficacy of these bispecific antibodies in the treatment for these patients, and the fact that it's a novel modality in the treatment for these patients. I'm very excited to see where this goes, especially like you said, given the disappointing data of CAR T cell therapy with this patient population. So great work, and thank you so much for taking the time to chat with me today.
Thank you for having me. It's been great discussing this.
Absolutely.